Hello, everybody, and you're all very welcome to our fourth seminar in the C6 seminar series. My name is Catherine Diskin. I'm a pediatrician that works at the Hospital for Sick Children in Toronto, Canada, where I work as part of the Complex Care Program. We're all very excited to welcome you to our seminar series that's focused on the clinical care of children with neurodisability and medical complexity. And the seminar series has a long name, but it's around collaborative conversations with families to advance the clinical care of children with medical complexities and disabilities. It's very kindly supported by the Lucille Packard Foundation for Children's Health in partnership with Family Voices. We're really excited to see all of you join us today, and today's seminar will focus on behaviour in child mental health. At the very start today, we want to acknowledge that each healthcare encounter is unique, whether it's brief or lengthy, and that many of the topics that we're focusing on this series are difficult to address by virtue of the fact that we're actually addressing gaps in research. And while we cannot cover the breadth of the topic, we aim to at least highlight the cooperative need and value of partnerships in healthcare. Just a few reminders to start us off. Please submit your questions and comments in the webinar Q&A. Once we have concluded the presentation, we'll move on to a panel discussion, and we'll try and get as many questions and comments as we can. At the end, you'll be asked to complete an evaluation survey, and it's an opportunity to provide feedback that we can improve on. You will need to complete this evaluation by Monday, December 20th to be able to claim CME credits. Because of the rich discussion at previous seminars with lots of questions and feedback from attendees, we've added 30 minutes to the conversation. And so at 2 o'clock, you're invited to stay for a coffee chat. If you can't stay, it'll be made available in the recording. And so our aim with this seminar series is that we can create a supportive forum and safe space to have really important conversations that ultimately improve clinical care. To do this, we've partnered with families because their participation is essential to improve clinical care. Families are our clinical partners in care 24 hours a day and 7 days a week. And because of that, their experiences and perspectives really matter. However, by virtue that this forum is large with many in attendance and virtual, the conversations that take place involve lived examples that may resurface a variety of reactions. We understand that these conversations can be difficult, and if anyone needs support after attending these sessions, we invite you to reach out, and we're going to share a number of links with you. We're really excited to have our family leaders with us today, Tina and Shonda, and I'm going to introduce Tina first. Tina is the proud mother of 5 amazing children who are aged from 6 to 17, all of whom are unique individuals with special needs. She is their cheerleader and ardent supporter. In addition to this, she's a project coordinator, a doula, perinatal educator, and health coach. In her current position at the Parent Information Center of Delaware, she partners with families to help them find resources and supports for their health and education. Tina, we're hoping that we can start with you and ask that you share an experience raising a child with medical complexity and developmental disabilities, and to tell us what that means for your child, for your whole family in terms of behavior and mental health, and also maybe even if you have time to share with us where you see opportunities for change. Thank you, Tina.
Sure. There are many examples. I actually had to narrow it down. I do have 5 children. All of my children are adopted through foster care. So they all have some trauma in their background, and they have various disabilities. They are absolutely amazing. I know every parent probably says that, but I am completely sincere. My children do amaze me every day, and part of that is because they do have so much to overcome. I live on the 95 corridor, which means we live in a community that has a lot of opioid addiction, a lot of challenges. I am fortunate we live between major medical centers and cities, but trying to find the resources to really support my children in their mental health and physical and all their disabilities is really, really challenging. And coronavirus has made that more difficult in some instances and better in others. So the one thing I do want to focus on, I have an 11-year-old son. He has autism and communication challenges. And I've noticed that the way he interacts with our community is very different from my other son, Dylan, who is about a year older. And so Eli is Black and Dylan is white appearing. He is biracial, but most people wouldn't be able to tell that. And we live in a community that has deep racial challenges, a very long and negative history. And I see it every day in professionals, in school interactions, and it really makes me fearful for his future. He is 11 now. He is going to be very tall and very big man. And already I see people treating him in a different way when he has dysregulation of his emotions, when he has outbursts, or when he refuses to do things. He has been hit on the bus by the bus driver. He has been restrained at school when he was in 3rd grade. And my other son, who has different diagnosis but has similar behaviors in school, has experienced none of that. And so, you know, we have worked really hard to find providers, appropriate psychiatric care, also resources for his communication challenges. But number one, trying to find pediatric support in mental health here where I am is impossible. And when you do find it, trying to access that support is really difficult. So for example, I have 5 children who all have various needs. So that means appointments and, you know, band and therapy, etc. Before COVID, I live about an hour and 10 minutes from our nearest major city where all of our therapies happen, etc. I would have to drive there 3 to 5 times a week with different children. I'd have to put all of my children in the car, drive, pay a toll, pay parking, wait with my children, all of them in a waiting room, and then potentially see a provider for maybe 10 minutes, and then load all of us back in the car. And the challenges are many, but one of them was that my sons would not interact with the therapist. So we would do all of this to get there, for them not to talk. One of my sons has selective mutism. So literally, we would go, he would sit and not talk. And so coronavirus, one of the benefits that I unexpectedly found was that I could suddenly access my kids' providers virtually. And that has been a game changer for us, because we could do social clubs, we could do all kinds of things that we could not have done if we had had to do that in person with him and with his siblings. So, you know, I really hope that some of these services, therapies, remain available virtually for families, which might have a whole schedule of different therapies and not be able to afford or not be able to access transportation and all kinds of things. So there are a lot of challenges that I've seen. One of the ones is how my providers work with me. You know, the ones that have been the most successful have looked at it as a partnership where they are available to me. I am available to doing things at home, to calling them, to letting them know what's happening. The ones that we have not had success with are the ones that are never available, that don't treat this as a partnership, don't listen to what I know, because I feel like I have a master's in all of these areas. And I will, you know, we'll sit down with a new provider and you can tell pretty instantly if they are going to be open to your feedback and your input or not. And so I think, you know, wrapping this up, that is kind of what I would want to see. Number one, the availability of services to be easier for families. Number two, really taking a look at our communities of color, how our Black and brown boys and girls and teens are treated and are able to access the services they need. And then also, you know, that partnership between parents, how can that happen and happen in a meaningful way? Not just like, yes, we hear you, yes, but actually building a partnership where the parent feels trusted and heard. Those are kind of my goals professionally and personally.
Thanks, Tina, for your incredibly moving story and for opening up our session. And I hope that we get to talk about some of the really important points you raised a little bit later. I'd now like to introduce Shonda Hicks. Shonda has been a program coordinator and family navigator at PAVE, P-A-V-E, a nonprofit that supports individuals with neurodiversity, developmental disability, and medical complexity and their families for the past 4 years. She has 3 children. Her oldest child is diagnosed with trichotillomania, and her son was born with Down syndrome. A lifelong learner, Shonda is in her 2nd year as a UW Lend Fellow in the Family Discipline cohort. Shonda, I know that you have experiences to share with us today, and we're delighted to hear them.
Thanks, Catherine, and thanks for everyone being here and taking the time. My name is Shonda, and I do have 3 children. I'm going to focus mostly on my son, who is 15 currently, and he was born with a diagnosis of Down syndrome. And I did know in utero that he was going to be born with Down syndrome. So it wasn't a surprise when he was born, but what the surprise came was afterwards when he was in the NICU for quite a long time, and the nurse would pull me aside and kind of reiterate that your son doesn't sleep a whole lot. He's very, very active. And so I took note of that. And when we came home, I really noticed that, yes, he does not sleep. In fact, at the age of under a year, there was a time when he didn't sleep for a full 3 days. So I knew something wasn't on point. So we went to our pediatrician, and they did refer us to a psychiatrist, developmental pediatrician at a local hospital. And we started seeing him when Grayson was about 2.5 years old. We started taking notes and seeing him regularly. And at about 3.5 years old, we started him on a medication for sleep at night. And I actually sat on the medication for a couple days because I was so used to the pattern of him not sleeping that I was afraid of giving him, my son, who's so small and tiny, medication and what that would mean for him. And I didn't want to harm my child. And all of these feelings like bubbled up as I looked at this pill bottle. And then I remember the night I gave it to him, I didn't sleep. He slept, but I didn't sleep. I was just like bated breath. Is he okay? Is he going to wake up? And he did, of course. And then the next day we both slept. And then we continued this pattern and realizing that there is most likely a brain chemistry thing going on with my kiddo that needed supports. So he's still currently on the medication at age 15. But since then, we did see that developmental pediatrician psychiatrist for years afterwards, and looked at the diagnosis of ADHD with him because he was so active. He did have some issues regulating. He had some executive function struggles. He had some attention deficits going on. So we started him on a myriad of trial pharmaceuticals, all of which didn't work. So we had some issues where when we gave him, he seems to be very sensitive to medications. And I gave him, I remember, just like a little nib of a small, tiny pill. And my son vomited for like 3-4 hours in my arms. And I just held him over a bucket for so long. And I called and I said, I don't think that's working. So we tried a different one, again, really small. And so we decided to halt for a while. And then he did take a medication called 10X for a couple of years until he ground his teeth down because of the jaw clench. And we decided to take him off of that, get some caps on those teeth to make sure he doesn't grind anymore. And then I started looking at alternatives to medication as a family and as a parent. We had the discussion with the psychiatrist that we had been seeing for years. And at that time, Grayson was about 8 years old. And the psychiatrist, after a long discussion, relayed to me, he said, I just don't think I can help you anymore. I think that this is now out of my hands. And I was essentially let go. And it felt like we were fired. And that was a really hard day. That was a really hard moment, reflecting. And I wasn't given any supports moving forward of who to see next or providers that could possibly help us. And I just felt very, very lost in that moment. So that's when I gathered my bearings and reflected on what can I do as a parent to support him moving forward while we research what providers to go to next. And so I took classes, and we took a lot of therapy classes. We did a lot of biobehavioral stuff. We did some play therapy to try to figure out what would work for him. Now that he's 15, we've been involved with the Seattle Children's Autism Center for a good 5 years. He does not have autism. He actually has been tested 3 times. But because he has a co-occurring diagnosis, it's really hard to pin a diagnosis of autism on a child that has a primary diagnosis of Down syndrome. So they decided to just enfold him into their work because there isn't a medical clinic that has the level of supports that he needs, but they do. So I'm very grateful for them for being creative, for being able to envelop him into their work. And that's where we took our first biobehavioral therapy with a provider, a psychiatrist. The cool thing, like Tina was reflecting about the telehealth piece, it's changed our world. I mean, really, we live in a very rural community, and I wouldn't have access to the level of therapy that we would if it wasn't for telehealth. And there was a situation where my son was actually in the car. He was struggling to get out of the car. There was a lot of oppositional defiance. I was in the thick of the moment, and I'm like, our appointment is in 3 minutes. So I get on the phone on the app, and I put the provider actually in the holder of my car. I said, I'm so glad you're here, and I apologize that this is going to be a little different, but we're actually in the moment. And he was like, fantastic. Let's walk through this together and see what we can do to help him out. Hey, Grayson, how's it going? The whole bit. And it did take him a good 12-15 minutes to turn himself around. We gave him the supports to be able to support him and where he was at, reassuring relationship, reassuring, confidence and that he could do this. And it was just such an aha moment for me that, like Tina was saying, you take a child to a clinic. For us, it's a 3-hour drive each way. You need a provider. You put them in a sterile room with 4 walls. You expect them to perform the exact same behaviors that they do at home, that you are explaining to this physician, that you are there for and you need help with. And the child is completely, exhausted, or they just are not going to speak. They're terrified. They don't know what they're there for. And you don't get the level of support, and you don't get that need met. So like you say, COVID really has opened up a broad spectrum of supports for us. And now at the age of 15, we have involved a lot of other positive behavioral supports into his therapy world. We do triple P parenting, which is a positive parenting program focused on positive behavior and giving attention to that as more than the negative behaviors piece. My son also has a lot of medical complexity, and I will throw that in that with pain, he does have a high pain scale on a regular daily basis. He has a lot of pain. So when he's having a high pain day, there is a lot of behaviors, and that means that that's a low expectation day for him. He's not expected to perform at the same level as he would if he wasn't in that significant amount of pain. So I'm grateful to the providers that have been creative and that have worked around the medical insurance piece and getting our needs met in that realm when things aren't covered. And, they go to bat for us on the back end. And yeah, that's a little bit of our story. I'm looking forward to hearing from the doctors.
Shonda, thank you. I think you speak so eloquently about the greatness of many families' experience and, the challenges around diagnosis and also medications and treatment. And I think you frame our next speaker so well. I'm delighted to introduce Dr. Antonio Hardin. Antonio is I'm losing myself. Antonio is a professor of psychiatry and behavioral science at Stanford University School of Medicine. He's also the medical director of the outpatient program in the Division of Child and Adolescent Psychiatry and the director of Autism and Developmental Disabilities. Dr. Hardin's research expertise is in the neurobiology of autism and in the development of innovative treatment. He serves as a principal investigator on numerous projects examining the neurobiology of autism and assessing the effectiveness of a wide range of interventions. Antonio, I'm delighted to open the floor to you and look forward to hearing you speak.
Very good. Thank you, Catherine, for the introduction. And I want to thank you for the invitation to talk about a topic that's I deal with on a daily basis. And for the audience here, even though I do a lot of research, but I'm a clinician at heart, and I've been seeing kids with autism and kids with complex neurodevelopmental disorder for the last 20, 25 years. And today is my clinic day, so I'm excited to be talking about this today. So let me share my slide. Very good. Okay. So how do we think about assessment and treatment of individuals with complex neurodevelopmental disorders? If it was easy, we wouldn't be meeting today, but it's a very challenging task when we see a kid with multiple disabilities, minimally verbal, sometimes blind, sometimes deaf, and we're trying to make a diagnosis or trying to develop a treatment plan for this individual. So usually we have grosso modo two routes. The easy one, but unfortunately not the frequent one, and the more complex one, and unfortunately is the frequent one. So let's start first with the assessment. So we have kids who come in with behavioral difficulties. I describe them like clouds because they change depending on the time of the day and depending on the setting. And they change and they are not as clear as we would like them to be in individuals with developmental disorders. But we try usually as much as we can to put these symptoms in a context of a specific diagnosis. If we are able to do that, we know that we can treat specific disorders. We have specific treatment for depression. We have specific treatment for anxiety. We have specific treatment for mood disorders. We have specific treatment for schizophrenia. So that's why if we are able to make a specific diagnosis, then we have specific intervention. And when we have a specific intervention, we see relatively frequently effectiveness. So that's a scenario that usually we try to work on. Unfortunately, it's not common to identify or to organize the symptoms in a way that will fit a specific psychiatric diagnosis. But that should be the first effort that everyone should do. What's the most common scenario? The most common scenario is you have behavioral symptoms. You try to put them in a context of target behavior or disorders, but you can't. So you try to focus on that specific target behavior. And instead of treating a disorder where we have a lot of science supporting specific medications or specific intervention to target these specific disorders, we don't have specific intervention. And that's why, unfortunately, we deal with a lot of lack of effectiveness. Here it's not effectiveness, it's a lack of effectiveness. So unfortunately, the lower the cognitive ability of the individual, the harder it is for us to make a traditional diagnosis. So that's why when we see a child, the first thing is to try to identify specific psychiatric disorders. And if you're not able to do that, we identify target behaviors and we try to treat target behaviors. Now, from an assessment and treatment point of view, as you all know, it's not very easy. To give you an example. So if you see a child who is agitated or is hyper, or gets hyper from time to time, or they express loud vocalization. Loud vocalization can be a symptom of the child being happy. It could be the symptoms of the child being upset, anxious, depressed, you name it. So anyway, a specific symptom or specific behavior could reflect on different things. Also, one other challenge with individual with intellectual disability or developmental disorder is that at baseline, they could have hyperactivity or they could have self-injurious behavior. So it's not a new onset of behavior that we're seeing the first time. And sometimes what we try to do, we try to look at a change in these behavior and the frequency of the intensity. Yes, it's true that Mike was having self-injurious behavior, but the number and the frequency and the intensity of these self-injurious behaviors increased significantly starting November of 2018 or 2019. So that's a little bit in the way how we look at these behavior. So what are the goals of the treatment? I think most of the parents realize that when we work with individuals with developmental disorder, cure is not part of what we are looking for. That's why we have to be realistic with the goal of the treatment. So this is an example of James. James is a minimally verbal individual that we work with for at least 8 to 10 years. And he came to us for disruptive behavior, anxiety, and severe obsessive compulsive behaviors. We worked implementing behavioral intervention, medication, and after 10 years, he was able to get a job as a janitor in a hotel. And as you think about the role of the person in the hotel when they come to fix your rooms, they have a specific task that they need to do. Here, what they've done, what the coach has done is James had 20 tasks that he needed to do in every room. And he developed this booklet, and it's on the left-hand side, bottom left-hand side, with the different tasks that he needed to do. And after a lot of practice, James was able to do these tasks, these 20 tasks, under the supervision of the coach first, and then of someone from the work. So it didn't happen overnight. It took years, but James was able to get to the point where he became a productive member of society. And here I put his first paycheck, and I think it was $16.51. So it takes time, and patience is very important, but we can get there, and that's the role of the treatment. So let's talk a little bit about pharmacologic intervention. People think that our role is just to medicate kids and ask questions later. That's not the reality. We're not pill pushers. The recommendation to assess kids is to look at it in a comprehensive manner, a biopsychosocial model. And the training that we provide to our learners or to our residents, fellows, is that you have to look at it like a bird or an airplane. A bird has two wings, an airplane, they have two wings. One is the behavioral, cognitive, and psychosocial intervention, and the other one is a psychopharmacologic intervention. It's important to have both of them, otherwise the plane will not fly or the bird will not fly. Now, for some kids, you might not need both, but it's important to think whether both are needed or not. And this is very important, and I give the example why. I give you the picture of two kids here. The one on the left-hand side is Corey. Corey came to us with five different medications for severe disruptive behavior. And when I asked the parents, what kind of behavioral interventions you're doing? They said, behavioral intervention? We tried something and then we're not doing anything right now. So I said, we're not doing anything with medication before you get behavioral intervention. So we pushed that. We identified someone to work with them, with the family and with the school. And without changes in any of the medication, he progressively got better. And actually, after 18 months, we were able to take away one medication. On the other side, you see Will. Will had severe anxiety and came to us after failing multiple psychosocial interventions. And when I asked him, okay, have you considered giving him medication? He said, no medication. No one has brought it up with us. So we started him on antidepressant, and progressively he got better, and he got better to the point that he was able to go to school, while initially they brought him to us because he was not going to school. So that's why it's important to look at both of these components at the same time and see whether there are indications for behavioral cognitive interventions or psychopharmacologic intervention. And I can tell you, I've been fired in the past because I put my foot down and I said, I'm not changing the medication because there is room for behavioral intervention here with the child, and you need to pay attention to that. So this is a little bit in terms of now general guidelines in terms of how to think about treatment. So first, we have to identify the behaviors and make a decision whether we want to target specific symptoms, targeting multiple specific symptoms, or things in general. Something you have to be aware of is that we don't see results as all or of nothing. Very rarely that somebody comes to us with significant behavioral difficulties and 6 months down the road, they leave with zero behavioral difficulties. We have to be realistic. So we have to assess whether there is a 20% improvement, 50% improvement, 75% improvement. And that's a task that's sometimes not very easy. And it has to be assessed. And sometimes we have to taper down the medication or decrease the medication to see whether we're seeing a real improvement or not. The other thing we want to do is to do one medication at a time. You don't want to add one medication for sleep, one medication for behaviors, one medication for ADHD, and see what will happen. You won't be able to figure out what is working. The other challenging thing that we deal with is assessment of side effects. It's not realistic to expect a 15-year-old who's severely affected to come to us and say, doctor, I'm having cognitive dulling from this medication. Usually you won't see that. You will see the behavior getting worse because of the side effect of the medication. So that's why it's important to be able to do that. And usually we train the parents so they will become a little bit like our eyes, so they can reflect on the potential side effects that the child is experiencing. Finally, and one good thing about working with kids is that if you prescribe a medication for a child at age 7 or 8 and they have either side effects or they don't see a response, we can try again the same medication 2-3 years later, because the brain is changing and there might be less sensitivity to the medication later on. Now, what do we know about sensitivity to side effects or lack of response? So this is a study in kids with autism. And we can, to some extent, not to full extent, extrapolate this experience to an individual with complex neurodevelopmental disorders. This study showed that individuals with autism, their brain is more sensitive to medication, and the response rate was less in the autism group than what you see in individuals who are typically developing and they have hyperactivity and inattention. And the clinical experience also in support of that. The younger the child, the more severely affected, the higher the chances that they have side effects, and the less likely they are to respond to the medication. That's why you have to be patient, and it's not unusual to try medications, multiple medication in a short period of time. So the challenge is sometimes to identify what we want to treat. As I mentioned, a lot of the kids that we deal with, they have multiple comorbidity, hyperactivity, anxiety, inattention, obsession, compulsion, sleep problems. And I usually ask the parents what we would like us to treat first. Sometimes parents say, you know, this hyperactivity, impulsivity is too much. Please, can you help us with this? So I have some other parents who say, you know, no one is sleeping at night. It will be great if we can start that. So that's why it's important to have a dialogue with the family to see where we would like to start with regard to treatment. Now we'll talk a little bit briefly about the different medication that we use. The first ones are the antipsychotics, medication like risperidone, aripiprazole. So the indication in general is for psychotic disorders such as schizophrenia or mood disorders such as bipolar disorder. But as we mentioned earlier, it's very challenging to identify these typical disorders in individuals with autism. So that's why, and based on the experience, we use these medications to treat irritability, emotion dysregulation, aggression, impulsivity, hyperactivity, mood swings, and sometimes in the absence of a clear-cut diagnosis of a psychotic disorder and bipolar disorder. And unfortunately, there are not that many medications approved for kids. There are 2 medications that are approved in kids for the treatment of irritability associated with autism, but not in other neurodevelopmental disorders, and they are risperidone and aripiprazole. Let's talk about the psychostimulants, medication that will treat, in general, ADHD, but sometimes we use it to treat the inattention, hyperactivity, and aggression. And you see a list here of the medication: methylphenidate, dextroamphetamine, mixed salts of dextroamphetamine, and lisdexamfetamine. amphetamine. And there is quite a bit of list of medication that we use. And as I mentioned earlier, there is increased sensitivity to side effects. There is evidence for increased sensitivity to side effects and less likelihood to response compared to typically developing individual with the same symptoms. Let's talk a little bit about antidepressant. I know I'm covering a lot of information here, but ideally, we'll need like 4 or 5 hours to cover all these challenges or these strategies in details, but we're going to try to put this information together in a reasonable way in a 20-minute period. So usually antidepressants are indicated for depressive disorder, major depressive disorder, anxiety disorder, obsessive compulsive disorders. Sometimes we can't make these diagnoses. I've been able to make these diagnoses, and we are able to make these diagnoses in some kids who come with a typical presentation of depression, dysphoria, suicidal ideations, increase in irritability, helplessness, worthlessness, hopelessness. So, and it's very easy to make that diagnosis. But sometimes we're not able to make these diagnoses. That's why we use these medications to target mood swings, irritability, sleep disturbances. For example, mirtazapine is sometimes used for regime of sleep disturbances. There is a large group of medication, the SSRIs, selective serotonin reuptake inhibitors such as fluoxetine and escitalopram. We usually use them for depressive disorder, but also for impulsivity, mood swings, and irritability. Anticonvulsants, these are medications that have been indicated for treatment of seizures, but with experience and some research, we found them to be effective in the treatment of bipolar disorders. It's very hard to make the diagnosis of bipolar disorder, a typical bipolar disorder individual with neurodevelopmental disorders. So that's why we use these medications for mood swings, impulsivity, aggression, irritability, and hyperactivity. And there is a list of the medication. Most of you might be familiar with valproic acid or lamotrigine. Now, there are other medications that are interesting. They've been looked at mostly in individuals with autism, but at times in individuals with other neurodevelopmental disorders. Medication like atomoxetine for hyperactivity, naltrexone for self-injurious behaviors, benzodiazepine for anxiety, amantadine for irritability. And there is a new medication, beta-adrenergic antagonists such as propranolol, that is making comeback, and there is significant interest in studying this medication and its effectiveness in the treatment of anxiety in individuals' neurodevelopmental disorders. Now, in an ideal world, we would like to have science to support our approach to aggression, our approach to sleep disturbances. But that's not the case. The ideal world, to some extent, is how we approach self-injurious behavior from a biologic point of view. There is evidence supporting that there are three biologic systems implicated in self-injurious behavior: the opioid system, the dopaminergic system, and the serotonergic system. When we are assessing or trying to treat an individual with neurodevelopmental disorder and self-injurious behavior, after doing our due diligence with making sure that behavioral interventions have been implemented and have been optimized, we try to target these three different systems separately from a biologic point of view. So if we could start with the dopaminergic system by targeting, by using a second generation antipsychotic or an antipsychotic, we can target the serotonergic system by using an SSRI, for example, such as fluoxetine, or by targeting the opioid system. And sometimes we do it systematically, or I do it systematically. I start with one, second, and I shift. And sometimes I combine two or three to try to target, for example, self-injurious behavior. This approach is based on science because of the basic science that's available, helping us understand the neurobiology of self-injurious behavior. Unfortunately, that's not the case for most of the target behavior that we see. And I cannot talk about treatment of individuals with neurodevelopmental disorder without touching a little bit on complementary and alternative treatment. As you know, there is no very well epidemiologic study, but if you ask adults and you check how many people are taking complementary alternative treatment, the numbers varies from 20 to 30%. However, when you look at kids with chronic illness, such as cystic fibrosis, juvenile rheumatic arthritis, or ADHD, the numbers are much higher, from 60 all the way to 70, 80%. And most individuals we see in our clinics, they are taking complementary alternative treatment. So how do we think about that? So I divide them in three categories: benign, with no basis in theory; benign with some basis in theory; potentially harmful biologically with no basis in history. So definitely we don't recommend using number three, with potentially harmful biologic compounds. And if you want to start between one or two, usually we recommend starting with benign biologic with some basis in theory, something like melatonin, something like N-acetylcysteine. So my recommendation to parents is that when you hear about complementary alternative treatment, don't get excited. It's very tempting to jump and to start something. we have to wait a little bit, or at least to be careful and lower our expectations with regard to the agent that we want to use. So that's why our approach is, with regard to complementary alternative treatment, it's happening more than we would like to admit. It's important to follow the same rules, one intervention at a time. Try it for 3 months, and if you don't know whether it's helping or not, take it off and see what will happen. No adjustment in concomitant medication, so you know what's contributing. And for parents, please inform the physician and the treatment team about these interventions that you are using. In terms of summary, how we think about treatment, medication treatment. So something you want to be aware of is that failed medication trials are common. You have to do regular evaluation, even when a medication is helping. You want to try after 6 months or 1 year, try to see whether it is possible to decrease this medication and stop it. Avoid polypharmacy, multiple medication as much as possible. Ask about complementary and alternative treatment. Be realistic. There are no simple recipes. When we see new patients, we tell them, you know, it's going to take 6 months to a year at least to be able to figure out what exactly is needed. A reminder of the importance of psychosocial intervention. Remember the bird with 2 wings. Behavioral intervention are very critical. And another critical component is the family role, educating the parents, training them so they can report to us any side effects. With regard to the future, I think it's important to identify objective measures for assessment of aggression, sleep disturbances. It's important to think about specific interventions versus non-specific intervention. And finally, combination of treatment. Unfortunately, the trial that's been conducted today have focused on one intervention, occasionally 2 interventions. We have to think like the field of oncology, where there is a combination of multiple intervention at the same time. And the hope is in the future that there will be trial or studies that will include multiple interventions, behavioral and pharmacologic, or 2 different behavioral intervention if possible together, or 2 different pharmacologic intervention together. And that's the hope in the future, and that's what we need to look forward to and push the system and push the specialists and the expert in the field to develop this kind of combined treatment. And on that, I would like to thank you for your attention, and I know we will have a part at the end and we will try to answer any questions. Thank you again, and thank you again for this opportunity.
Thank you very much, Antonio. Before I introduce Dr. Belzer to everyone, I'm wondering if Shonda or Tina have any thoughts, having heard just what Antonio said.
Yes, lots of thoughts. I thought it was so funny to me that I understood all the medications you talked about, all the intervention, because I have had experience with most of them and working or not working. I do want to say, when you were talking about complementary and alternative therapies and using one, I just want all providers to remember that this is, you know, your job, your profession, but this is our life. And, you know, at the point where I was so desperate to get sleep, where I was so desperate for my child to have a good day at school and not to get a phone call, like I would, and I'm going to be honest here, I would do anything. Crush up some snails, put them in his water at 3 o'clock, and I would do anything. Like, you know, as a parent, there is, I'm going to be, there's a level of desperation that I thought, I always thought it was funny, you know, not funny, but I would talk to, you know, my developmental pediatrician or psychiatrist, and I would say, I need help. And they would say, oh, well, let's let the medication work. Let's keep on this medication for another 3 months. And I'm thinking, 3 months, like I don't know if we can survive 3 months. Like I don't.
Yeah.
So just remembering kind of that reality that yes, there are some of us out here like, is there a diet? Is there like some magic words I can say? Like I'll do it, because the disruption for the child and for our lives is complete and takes over and is very difficult to live with. So I appreciate that in a scientific context, having to know exactly what they're taking and allergies and all of that. But on a real context, you know, families are desperate sometimes, a lot of times. And, you know, and I think sometimes providers need to hear that, you know, the way that we're feeling and coming at the situation is desperation.
Yeah, good point, and I definitely agree. And that's why, in my mind, I divide the family in two groups, like rookies versus veterans. Like you're definitely a veteran here, and which means that you've gone through a lot, and usually the reaction with regard to a kid who's been through a lot is more aggressive than a kid that's coming to see us for the first time, a family that's considering a medication for the first time. I think Shonda mentioned that, like she didn't sleep when she gave the medication to the kid. So in a way, we have to titrate our approach based on the presentation, while keeping in mind, keeping the scientific hat as much as possible, but to be mindful of the crisis that's in front of us. But definitely good point.
I think that this is the perfect opportunity to introduce Dr. Belzer. Leslie is a pediatric psychologist at Children's Mercy Kansas City and an associate professor of pediatrics at UMKC School of Medicine. And her specialty is integrated complex care, serving children and youth with special healthcare needs, their caregivers and siblings. She's passionate about family engagement, and she serves as the faculty champion of the Children's Mercy Patient Family Advisory Council for the Beacon program, leads the International Behavioral Health Affinity Group of the Complex Care and Disability sake for the APA, and trains fellows and practicum students as well as many medical learners in complex care psychology. Leslie, we've been talking or hearing about the trial and error and the need for a titrated approach, and I'm so curious to hear if you can, like, you know, help us. How can we better support providers and families work together to troubleshoot this, but also like manage that whole experience of uncertainty? And we would be delighted to hear what you have to say.
Thank you for having me. I am very passionate about family collaboration in our behavioral health care and working together with specialties like psychiatry, developmental pediatricians, our PCPs for primary care, social work, school teachers, anyone who is in and around the environment of the kiddo. And parents are our experts. You are our medical experts in the home setting and sometimes in the school settings. And sometimes you have care workers in your home who can also be experts. And so there were some common themes and common threads that came up today in this discussion that I think I'll highlight and just make a couple of recommendations. So one of them is clinicians, we need to be really creative and flexible to work with families who have kiddos with complex care needs. We really need to meet them where they are. So as Shonda said, if we need to go to the car, we need to go to the car. If we need to see them via telehealth and the parent can hold the screen up to the kiddo or send us videos, take sort of data notes of a behavior, what happens before the behavior, what happens afterward, the time of day the behavior happens. They're the experts, you are the experts. And so that information can really guide our interventions. And as Antonio said, decide kind of what medicine to try first. If the behavior interventions aren't started, which ones to bring on board. And so we'll know what what is working and when. Families are the most important in communicating that to us because you're the expert observers of your kiddo, right? And so partnering with you is the most important. And if you have a clinician who's not using you to your full potential, let them know, hey, I have a spreadsheet about this. Would you like to see it? Or I have a bunch of video clips on my phone from the bus ride, or in the car. Would you like to see that? And then creatively problem solve. Another thing I would recommend is that clinicians need to be willing to partner within the systems, as Tina was mentioning, within the systems that are affecting the child. So while we may not be able to, during our clinic, attend school meetings with the family, we can partner with a parent like Tina to say, you know what, if your child is experiencing some form of systemic racism, that you feel like because of his communication needs, that if he's aggressive and that's communicating something to the team, but they're interpreting it more harshly, possibly because he's a person of color, let's bring that to the forefront and let's support the parent in communicating to the school, hey, no fingers pointed here, but we really need to look at our history in this city, in this clinic or this school system, and think about how we can partner together to break down barriers of systemic racism and change the story for this kiddo. And we want his tantrums to be looked at like tantrums, not aggressive behavior. We want him to grow up and be safe. And we as providers and school teachers and clinicians and parents, we can work together to communicate that really important, powerful message. And I'm committed to acting on families' behalf for those issues. And I think that's an important piece that you mentioned, Tina. And then the very last point I want to make is that if there are gaps in services in rural areas, clinicians, we need to be really creative with families about how to bring services to them. And if mental health or behavioral health, psychiatric care isn't available, we want to try to bring it and embed it to whatever setting the child is in. So partnering with other institutions or satellite clinics, using telehealth interventions, providing, for example, Wi-Fi if is needed in some setting that's already established in the community, and sort of piping in our services into the family's home or the setting where the child is, so that we can break down these health disparities that are occurring, because no child and no family should be desperate. We know that that's the feeling that you're communicating to us time and time again, but we really want to work with you to improve, and we can. Thank you.
I think you bring us up to just 2 o'clock. And so we're going to continue this discussion portion of the seminar with all of our panelists and anyone who can join us until 2:30. So please just stay in this Zoom. For everyone else and for everyone indeed, thank you for joining us. We hope you enjoyed it as much as we do. And a special thank you to Antonio, Shonda, Tina, and Leslie. Please fill out the survey by December 20th. And our next seminar is on Thursday, January 13th, where we will focus on shared decision making, joined by David Fox and Jodie Lynn, along with our family speakers Jill McCormack and Brennan McCormack. And registration for that is open now, and you will receive the link. Otherwise, please hang out here, and we will be continuing our conversation around this topic. I see we've been asked in the chat about where we can find recordings. They're all hosted, including those from previous seminars, on the Lucille Packard Foundation website. I wonder if a good place to continue the conversation is hearing what you've heard from Leslie, Shonda, and Tina around partnership and creativity. I'm wondering what you think.
Yeah, I definitely, I don't think we would be in the space we're at currently if it wasn't for some of those real authentic, transparent conversations with our providers, actually taking both of our hats off in the room and getting down to what's really happening. And a lot of times when you come into a room as a parent, there is a little bit of a wall that we put up because we have been so desperate. We have been in this place of trauma, and we've been in this place of, we'll do anything. And so we come with all of our, I hate to say baggage, but we do. We come with all of these emotions that are convoluted in us. And being able to, as a provider, support those pieces in a way that we can get to next steps and get to healing, and then also get to our child getting supports that they need. Relationship, that's all I can say, is building relationship and establishing and keeping relationship and those lines of communications open, and building a creative future for my kiddo has been beneficial to our whole family. I mean, when he thrives, we thrive. When he is able to re-regulate and regulate his own behavior, we celebrate, and it's not unnoticed by any means, because trust me, we have an 11-year-old that this week she even said, "Oh my gosh, did you see that? He was able to turn it around and no one even said anything," and so giving him the tools in his tool bag, I mean, he'll be an adult here soon. And it's super important to send him out into the world with something to be able to rely on. And that's in the home. And then that's our job, to be able to have those bits daily with the guidance of a physician or guidance of a therapist to fall back on. This is working, this isn't, and help disseminate those pieces.
For me, similar. The relationship I have with providers is critical to getting good care. And so an example, we had a whole range of therapists and psychiatrists previously. And a few years ago, we moved to a practice where the provider is a Black woman. And for us, this was the first time we had a psychiatrist, a Black woman psychiatrist. And it has been so amazing for us, for my children. Representation really matters. With Eli, when we're talking about his behaviors and how they're perceived in the community and how that puts him at risk in situations, she has had the same conversations with her son. She understands what I'm talking about when I say that Eli can't, on the bus, have a tantrum because he might be harmed. And I don't get like blank stares. She understands the racism. She understands the fear that I have as a parent. She understands the medication issues, because children of color are often over-medicated with antipsychotics, with lots of medication in order to, subdue them, and less focus on the behavioral pieces. So, as a parent, I want my kids on the least amount of medication and paired that with behavioral interventions. But a lot of the psychiatrists and therapists we were working with would just throw medications at us. And like, Dr. Hardin was saying, we would have medications, and then we would have medications for the side effects. And then we would have side effects from those medications for the side effects. And it was ridiculous. It was destructive to my children, to their health. All of that. So having a provider that understands that, and that is how to understand your family, whatever your cultural, ethnic whatever your background, understands you and where you're coming from is so important.
Absolutely. Tina, I just want to echo that sentiment. I know representation matters so much. And in the field of behavioral health, a lot of times you might not be able to get that for a specific culture, religious background, racial, ethnic group. And I want that to happen. But as a white female, for example, my job is to understand you with cultural humility, understand your child and the systemic health and racial disparities that might be going on in the environment, and educate myself, reflect on my own biases, and then still meet you where you are and meet your child where you are. And that's the task I think that we all have right now as clinicians. We really need to prioritize this work with families.
I just want to offer Antonio, if you have anything that you want to add when we hear this really important topic crop up a number of times in the past hour.
Yeah, I think, again, look at it from a training point of view. It's important to train the new generation of physicians, of clinicians, about the importance of being culturally sensitive. And if you look at the curriculum at this time compared to 10, 15 years ago, you see a significant shift. The new generation are getting more training in cultural sensitivity. There are books actually on that people are discussing in Journal Club, because it's a partnership. If I don't understand you and you don't understand me, it's a no, the contract is not there, and the improvement that we would like to see, we will not see. So that's why it's important to highlight this cultural sensitivity, understanding where the family is coming from. And every family comes to us with their different story. There might be the same ethnic background, the same racial background, but they come to us with a different story. And that's why we have, as clinicians, to be sensitive to that specific cultural background and titrate a little bit our approach accordingly.
I see from the questions and answers and comments around in the chat that this is a very real experience for many people and something that we need to be very mindful of. Shonda, I don't want to put you on the spot, but I don't know if you have any comments that you want to add before we move on.
None around the racial disparity and health disparity piece, but I did notice there's a comment about family, supporting the family through the diagnosis. So I don't know if you're going to touch on that. I'd love to comment on that if you were, Catherine. You're muted.
I muted myself. I was going to go, like many of us are generalists in clinic without a behavioral health expertise, and I was thinking, you know, of the family and the children, and what tips would people have for generalists supporting families and supporting children, and how can we do better, and what are things that practically we can do in our practice. And then Shonda, I think your comment probably will feed into that, right? Maybe.
Yeah, no, absolutely. And I think that where my thread was going is going into a provider's office. And I mean, I'm going to speak for Tina. We see a lot of therapists and providers weekly. We see a lot of faces that go through our, you know, our regular day-to-days. And every so often one will ask me, and how are you doing? And when that happens, you know, a couple reactions come to mind. Either if I'm in the middle of a lot going on, I'm fine, I'm great. You know, I don't have time to address this. I'm busy. I've got another appointment, and, you know, or it'll be, you know, the floodgates open, and no, I'm not okay, and I do need support and help, and I don't even know who to ask or where to go, or, you know, who that would be. But through the journey, I mean, I've been in this for 15 years now. through that journey, you learn to create social support networks. You learn to create professional support networks. You have your little lifelines that you reach out to for those bits. But it is important, I think, as clinicians to tap into, especially the primary caregiver. How is your burnout? How is your, how are you doing? Are you sleeping at night? Are you getting rest? I hate to use the word self-care because it conjures bubble baths and pedicures, but real self-care. Are you taking a break? Are you getting respite? Are you able to go somewhere and defrag and be able to be there for your kiddo? Because you can't help your children if your bucket is just overflowing with your own stuff. You have to be able to triage that and mitigate it and work through it and heal while you're still caregiving, even though the trauma is still laying itself on you. So for me, that's a big one, is making sure as clinicians or therapists or anyone that's touch pointing with a family that has high needs, just asking every so often, how are you? And being authentic and really meaning it.
Thank you, Shonda.
I think I want to, in the question and answer, there was somebody talking about, they hear parents are the experts, veteran parents are more aggressive. And I want to talk about that too, because I think for some interactions I've had with professionals, I have been like the blank slate, right? They care about the child, what's going on with the child. They know very little about me and could care less, right? Unless I am the squeaky wheel. And I think a lot of parents of children with disabilities get to the point where they are tired of screaming and no one hearing them, tired of seeing things and bringing it to the attention of the pediatrician and nothing being done. And so they get aggressive, I guess. They get demanding. And I think a lot of parents lose trust that anybody is going to actually be able to do something. And so I think just recognizing that you are also meeting the parent where they are. They might have, Dr. Hardin was talking about one of the examples, James, I think it was, who, received services and then got a job and got a paycheck, right? What I saw when I heard that experience was his parents put so much work into getting to that moment, right? So many sleepless nights, doctor's appointments, waiting at the pharmacy, fights with insurance, fights with the child, diaper wetting, endless. And, it's great. Like at the end, he's, an adult with this picture and got a job, and that's great. But like his mother could be like a shell of herself right now because of the trauma that she's gone through. And so then when she interacts with a new provider and she's aggressive, yes, she's aggressive. That's why, right? Because we have to be warriors all the time. And I can't always be a nice warrior, because nice women don't get things done all the time. And this is what we know as mothers. I can't speak to the experience of males, but as a mother, sometimes if I don't get passionate and raise my voice and get insistent, nothing gets done for my child. And I think that needs to be recognized as well, is that we are fighting sometimes 24 hours a day to get these things done. And this is our life. And that is reflective in our communication with the school, with the providers, with everybody. Sometimes there is a rough exterior. And I don't want parents to be thrown away or not, listened to, because they do have that exterior, because they have earned it through their experiences.
Thank you, Tina. Absolutely. And Antonio, I know I can see you want to comment as well. I'll just quickly say that I see you. I appreciate you. I love the mama bears and the papa bears and all that you're doing because you're advocating for your kiddo or your kiddos. And the way that I would like to encourage generalists, pediatricians, others working with families who do not have mental health folks on board would be to use these words, to say to families, I see how much you love your child because of your strong advocacy, because you are passionate. And I'm not going to take offense to that. I'm going to partner with you to see what we can get done. And I think those words can help us to come alongside of each other. Our job as clinicians is to bear witness to your journey with your child, not to be the expert and be defensive and work against you, but to walk alongside of you.
Yeah, I think when we talked, I think we had a meeting before this one a few weeks ago, and what I shared is that what keeps me working with this patient populations are the parents and the mother bears and the fathers, who they won't leave any stone unturned for their kids. And I gave many examples over the years what parents would do with regard to getting the best treatment for their kid, the best complementary alternative means, the best experimental treatment to get them to do it. And this is humbling for us. You know, I'm a parent of 2 kids who, you know, they're typically developing as far as I know, and looking at the parents and experiencing them. And part of our work in mental health is that we grow with these families. Like I have family I've been working with, I've been at Stanford for 15 years. They were kids. Now some of these kids are transitioning to group homes. Some of these kids going to college. It's nice to follow them along these lines and being part of that family. I'm not part of the treatment team anymore. We're part of the family. And, you know, to see what parents do, how the miles that they will drive to come to see us. And Tina, you mentioned about the mother of James, and I can tell you a little bit what the mother of James did. It's like, I wanted to mention it, and usually I mention it, but for the sake of time, I didn't do that. So when James got this job, there was a question to how he's gonna get to that job. You know, who's gonna go drive him in the morning and bring him back? So they decided to maybe try to see if he can go on the bus. And the bus ride was about 30 minutes. But you know, James could lose it at any time on the bus. So there were meetings with the bus driver, with the group of the bus driver, because there would be one in the morning, one in the afternoon, and there was the replacement. There were several meetings that, and guess who was there? Mom was there. I was not there, but mom was there. And then when they started the practicing going to the work, the coach was on the bus with James, but mom was driving behind him in case James has a temper outburst and he needs to exit. So they did that for several weeks. And after people felt comfortable that James can be on the bus with the coach stopped riding on the bus with James, but would ride with mom, and mom would drive in the morning and the afternoon behind the bus. So this is just to take the bus. Think about the pharmacies, about the other behavior. So I think it's a no-brainer that parents' involvement is key for the success of our children.
Well, and then the things that we don't talk about, which is that our children with disabilities are vulnerable to bullying, to sexual abuse, to being taken advantage of. And as mothers, as their parents, there is a lot of fear, especially in that transition from, you know, high school, from teenage years to adulthood, and somebody hurting our children that we have worked tirelessly to support and to get into a good place mentally, physically, emotionally. And then we put them out in the world, just like all parents with their children. But our children have additional challenges. and they have predators that will target them. And so I think as people don't realize the extent of the amount of worry and emotional investment that we have, families of kids with special needs have. It's not just the typical things. It's this whole range of problems and challenges. And you mentioned earlier about, you know, parent support. I would not have survived as a parent of children with disabilities without the women around me who experience similar things, and having them to cry with and to be with, and to, I mean, you know, our children don't all have the same disabilities, but they have the same worries. But I, you know, think about those parents that don't have that support and are doing this alone. It is unimaginable, really.
Leslie, in the chapter, there's a lot around, you know, parents not wanting compliments on their tenacity, but also a need to keep it real, or that rather our speakers have kept it real today. And I'm really interested, before we go to wrap up, if you have any thoughts on how we as providers can be mindful of the parent experience, and how much of what we ask is actually an ask of parents and family caregivers.
You're absolutely right. So parents are the hands, feet, eyes, every other piece that we need in the home and other environments for this kiddo. And I think acknowledgement and just letting parents know we're here to partner with you. How are you doing? Like you said, Shonda, what can we do? And then the way that you all discussed and Dr. Hardin mentioned, we have to start with what is impacting you the most. If you're not sleeping at all, we need to hear that, and we need to help you get some relief. And then we can start to work on something else. You know, maybe toileting can wait, if or working on something else. Maybe we can keep the tube feeds for a little while and work on swallowing later. If no one is sleeping and there are safety concerns, we have to really work on what you need us to work on. And that means listening and taking the time to listen. And I know that time can be short. You mentioned 10-minute visits, for example. What could any of us get done in 10 minutes? And so being able to communicate with you in visits and then outside of visits, for example, through patient portals or some type of communication, and then having that back and forth to solve problems collaboratively is essential.
Thank you. I'm wondering if I can go around the panel and kind of ask everybody that when they reflect on the last almost 90 minutes of conversation, what are you thinking now, or what are your final thoughts? I'll do the awkward roll call and start with Antonio. Antonio, you just muted.
Yeah.
Thank
okay,
you.
I just noticed that there was one comment in the chat, and then it will, regarding the doctors and parents, they shutting down when doctors become accusive or stuff. It's, you know, parents work very hard to get to see us, and you know, I'm guilty at times not being as sensitive as I would like it to. And maybe sometimes we say words, or we make statements, or we ask questions not the right way. And, you know, I've been doing this for like the 25 years, and I keep getting input from families about how we can do things better. I think educating the clinicians about where families are coming from, that if they are in front of us, not because they didn't do what they're supposed to, but maybe they've done all what they're supposed to, and it's not enough, and that's why they're coming to see us. So that's very important, and we keep working on that within ourselves, but also with the new generation to understand where the families are coming from. Mm-hmm. With regard to in terms of wrap up, I think we talked a little bit about the families, and I want to emphasize the role of the families with regard to pushing the system to provide more for this patient population. As you know, clinicians, we can try, but we kind of looked on at we being biased because this is business for us anyway, for people look at it from this business. And as you all know, we don't want more of this business. We're very overwhelmed. But with regard to the mental health services, the support that families would need, so we need, you know, the parents to advocate at the local level, regional level, state level, international level. People mentioned, I think Tina and Shana mentioned the virtual visits these days. You know, we cannot do virtual visits outside our own states because of federal laws and different laws. And as you know, expertise in this patient population is not available everywhere. So we need to work a little bit harder to create some flexibility in the system to allow us, like, for example, maybe people in Kansas, if you have an expert in Kansas who is the best person with regard to toilet training, and you've tried the people who are working with you in California and they were not very helpful, to be able to reach out to that individual on a consultation basis, on a maybe a trial course basis. And that's where I think we need parents to change that. You know, the early intervention law that were passed in different states to provide ABA for kids with autism. It didn't pass because I wrote a letter. It passed because we had parents pushing the legislator to make sure that early intervention is available, or ABA is available for kids on the spectrum. And more approaches like that should happen, not only for behavioral intervention, for respite, for behaviors, for all of the above.
I wonder, Leslie, how you want to follow that.
I'm thinking for the parents who have zero time, they're the ones that have to do the policy advocacy. It seems so unfair. So I'm hoping that we can partner with families to continue to get that message out, because I completely agree. We would love to be able to consult with you where you live, from Kansas, for example, but there are these barriers that prevent us, and the pandemic helped us to be able to have a little bit more freedom with telehealth, but we're kind of fighting to keep that ability to even continue to do televideo visits. And so we do need parents and caregivers to be vocal about what worked for you and what you want to keep when we do solve a problem or we do improve. Letting others know. So I really appreciate that. And I just wanted to say I'm really energized when I get to talk with families and with this team. I really appreciate hearing from you. And it's just such a good reminder that parent panels are our most important education tools when we're training new clinicians. And I will never forget that.
Thank you. Tina?
I think that I co-sign what Leslie was saying. I think the only way that things are going to change is if you get providers and parents in forums like this, having discussions but having real discussions. So I've seen a couple of comments where people have thanked me for being real. And that is, we should always be able to have these real conversations, because we're not going to change anything by, sugarcoating what's going on in our communities. And, parents often get frustrated and mistrustful because what they're hearing is not a reflection of what they know is happening in their communities. And focus in the media and everything is going on other things when they are dealing with racism and the breakdown of insurance systems and all of these kind of things at a real level, and they need to have these conversations. And my professional life is about supporting parents having these conversations, but I think that this kind of dialogue needs to happen a lot more. And yes, and someone just commented, and I agree, policymakers need to hear these conversations and be involved, because that is one way to make change happen.
Shonda, our final words are with you.
I just want to reflect on the relationship piece between provider and family. I think initiating, building, and keeping relationship in this lifelong, because we're in it for the long haul. We have children, then we have teens, then we have adults, and they're constantly under our care, and how that ebbs and flows and changes, and being able to be like water with these families like mine, and go with the flow of where we're going, and trying to understand and support where we go and where we're going through the transition pieces of life is super important, especially when it comes to mental health and the whole of the family. And I appreciate everyone saying how real this conversation was. I feel it was very authentic. I feel like we really brought up some very valid, real points from myself and Tina that we were able to bring to a clinical setting and kind of pull those pieces out of a didactic and work together. And I think that it furthers relationship. When, parents have a PhD in life experience and we're able to bring that to the clinician, and they respect that. And they're like, oh, you can talk my language. And we have these real, authentic conversations so they get somewhere. So I appreciate everyone's time completely, and I appreciate everyone staying over a few more minutes after the conversation. And thank you, Catherine. Thank you, Eyal. Thank you, Rishi. And of course, thank you, Antonio, Leslie, and Tina. I appreciate this so much, and it was fantastic use of the afternoon.
I'm only delighted that you've done my job for me, and I just have to say thank you very much to everybody. The slides will be available in their usual place, and we're looking forward to January, and wish everybody a nice few weeks in the in-between.
Thank you.
Good. Thank you.